Hi, my name is Annalisa Baldonado. I am a Doctor of Nursing Practice student of NORCAL DNP Joint Program of San Jose State University and Fresno State University. My presentation today is Avoiding Readmissions Initiative. The objectives are for me to introduce my DNP project. I will be discussing the project context, presenting the methodological approach, and lastly, the evaluation. Readmissions is a hot topic nowadays because a healthcare organization's high readmission rates are considered a mark of lower quality care. CMS can penalize hospitals for excess readmission rates. The table shows the different penalties imposed to hospital. In year one, the conditions are heart failure, MI, and pneumonia. Succeeding years, it includes the COPD, coronary artery bypass graft, PTCA, and vascular procedures, which amounts to 2% penalty. The succeeding year, it expands to other conditions and costing 3%. We are not only talking about hundreds and thousands of dollars, but also it can amount to millions and millions of dollars of penalties to other hospitals. Transitions of care is a vulnerable time. I want you to stop and think what happened to the patient that you discharge. Do you know that 62% of medical patients had an adverse event and 72% were adverse drug events? Other types includes readmissions, ER visits, pressure ulcers, infections, and falls. How about from the patient's perspective? A study done by Macarius and Friedman in 2005, investigating their post-discharge phone calls, results to 41.9% of patients that could state their diagnosis, and only 27.9% could list their meds. 37.2% knew the purpose of their drugs, but only 14% of them can state their common side effects. I want to show you my hospital setting. This is Veterans Affairs Palo Alto Health and Hospital System. In the left side is an overview of the facilities. So we have 3 inpatient facilities, which is Menlo Park, Livermore, and Palo Alto. We have about 900 beds catering to about 85,000 of veterans. We have 7 outpatient clinics, so we are closed system and integrated. We are also a teaching hospital and a research center. On the right side is a triangle, which is our path to excellence. We cater to veterans with a vision to be the benchmark of excellence and value in healthcare. We have a mission to honor the America's veterans by providing exceptional healthcare that improves their health and well-being. Included are priorities and core values. My PICO question is stated as, for the population, adult heart failure veterans, intervention, transition coordinator, advocacy plan, comparing it to the current practice and with a general outcome in looking at the to avoid readmissions. So my PICO question is, among the adult heart failure veterans, will a transition coordinator advocacy plan compared to current practice avoid readmissions? Included in my intervention is Project RED. Project RED is arranged in our discharge with 11 components and is a random controlled trial aimed to decrease readmissions by 30% and also increase patient satisfaction. This is a 7 years work by Boston Medical Center, funded by AHRQ and NHLBI. It is a safe practice endorsed by IHI, LeapFrog, CMS, and exceeds the Joint Commission standards. I want to share you the success stories of Project RED implementation. In Glacial Ridge Hospital, their pneumonia readmission rate was 4%. Post-implementation was 0%. For COPD, 20%, post-implementation, 14%. Now, in Northwest Lake Forest Hospital, they had a readmission rate of 38%. Post-implementation, it went down to 10%. For Temple University Hospital, their heart failure readmission rate was 24%, post-implementation 12.8%. Really, very inspiring indeed. Now, what are the RED elements? It includes educating the patients, scheduling their appointments, discussing their tests and studies, organizing their post-discharge services, medication reconciliation, the use of national guidelines, and reviewing to them what to do if the problem arises, and also expediting the discharge plan to the next clinician. Also includes teach back, follow-up phone calls, the use of after-hospital care plan, and language assistance. In my previous slide, it says 11 elements, but now currently they have included language assistance. I look at the different populations at risk in implementing these transitions of care. The first trajectory are healthy veterans with new onsets of new chronic illness. These patients are in denial and still adapting to this new chronic illness. The trajectory 2 are veterans with multiple chronic illnesses. And lastly, trajectory 3 are veterans at end of life. I want to share you my SWOT analysis. For the strength of my project, it is a quality improvement, avoiding readmissions initiative, implementing Project RED. This is an evidence-based in improving patient outcomes recommended by major organizations. It is highly recommended, and we are also the first organization to be implementing the whole 12 components. It started in the inpatient hospital setting, extending to outpatient services, wherein the strategies are patient-centered care, teamwork, collaboration, implementation of evidence-based solutions. It is a continuous QI process with the use of informatics and commitment to safety. The weaknesses is that with after-hospital care plan software, it's creating a bit of a challenge. We're putting a lot of energy and time because it needs to be integrated in our EMR. In doing that, we're having a low patient census in enrolling to our Project RED because of the multiple processes involved and no standardization. But however, there are a lot of opportunities for us to grow. It would improve the veteran outcomes, and we are the first nation to lead this initiative that could be copied or duplicated to all VAs. We act as a resource to other hospitals and many opportunities for evidence-based projects and research opportunities and eventually publication. What are the threats? We need more resources. We need a buy-in and support from key stakeholders for palliative referral and hospice referral. And also the barriers includes resistance to change, politics, and culture. The heart failure model I will be using is a discharge strategy, which is a pilot study. I have 30 patients who are included. These are male, diagnosis of heart failure with a telephone, and excluded are transferred from different hospital patients under hospice care who are admitted for a planned hospitalization on hospital suicide watch, who are deaf and also blind. I'm comparing it to the usual discharge process to my transition advocacy plan. The process includes a risk calculator, risk assessment tool, educating the patient using the components of Project Red with the health literacy, motivational interviewing, and I also use an encrypted internal email, sending it to the patient-aligned care team or the clinics, and also to the inpatient team when the patient is admitted. I provide updates, and also when the patient they are notified when the patient is discharged. The transition collaboration includes the use of clinical pathways, networking with community partners like the clinics, home health services, and skilled nursing facilities. I utilize the home telehealth. I do follow-up phone calls, and we are available. We, as transition coordinators, are available for veterans for, to be, if they wanted to call us post-discharge to answer the questions, we are there. Now, the methodology, it is a quality improvement project in concurrence with the Project Red. It is a preliminary investigative feasibility in a small scale and exploratory in nature. Thereby, it is an exploratory descriptive design in which, after I am able to lay out the strict steps of this, I will go ahead and pursue it as a research study. The timeline, this is my Gantt chart, so I'm just gonna be stating the different milestones. So I had my Stanford IRB like last April of 2013 and passed my QA in May, and my Fresno IRB was approved in June, and the implementation started in August, last week of August. As of the moment, I'm still collecting my data. I was able to publish one manuscript last July, and hopefully my second manuscript will be published by end of January. And also currently I'm looking at poster presentation opportunities, and the project completion will be in April. So that's my timeline. Looking at the evaluation phase, I'm looking at the return of investment. So return investment equals to gain minus investment divided by investment. So I'm looking at both the cost and benefits, and the beneficial return is two prongs. I'm not only looking at the financial return, but also the non-financial. Talking about this is also geared towards the evaluation, in which in the education part, I'll be looking at if there's an increased knowledge for self-management, and in the communication and collaboration, if there are improved connections with PCP and other providers, improved medication compliance, increased patient satisfaction, national guidelines implementation. And for the readmission rates of heart failure patients, I am gonna be looking at hospital utilization and length of stay. In summary, I have provided an overview of my DMP project, presented to you an evidence-based model, and my methodology, and lastly the evaluation. As I end this, please do allow me to state a quote. As a VA employee, we strive to exceed the expectations of veterans and their families. We strive to perform at the highest level of competence and take pride in our accomplishments. Thank you so much for this opportunity. These are my references, and if you have questions, please do post your questions. And again, thank you. Thank you so much.